Have you ever wondered what a day in the clinic is like for other practitioners? What do they do with their clients that may be something you might want to try in your own practice? In today's episode, I share a day in the clinic with me and how I treated six different interesting cases. Listen in to hear what I found and how I treated my clients.
Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started.
Hello, and welcome to this episode. And today I thought I would share with you a day in the clinic with me. And I just had a day the other day where all of my clients just had really kind of something cool. So I thought I would share somewhat of their history, why they're seeing me, and what I found. So let's start off with person number one. This person came to see me with tailbone pain. This was my fourth time seeing her. When she originally came to me, she was 4 months postpartum, had a tailbone pain and a 3.5-degree tear, is what she reported. So it did involve her anal sphincter muscle. And she also complained of being constant, having lifelong constipation. She had to do IVF to have her baby. She had a history of a fissure that was lasered and it healed. Um, she doesn't have any pain with bowel movements now if they're soft enough. What I found in her body, and there's, I'm sure, other stuff that we discussed, but they didn't make it into my notes. So, what I found was that her sacrum was in flexion. She had the common birth pattern that I find. I treated her in prone to help treat the sacral flexion. And then I also found her right broad and uterosacral ligaments tight. So I released those. She definitely had scar tissue internally on the left side. Her bladder was pulling down into the left. Her cervix was tight posterior, which to me, when it's posterior tightness, that's a sign of tightness in the uterosacral ligaments. So, but I did treat that. She did have a left ischial splay that I found, and lots of tension in her pelvic floor muscles, which um, could be contributing to her constipation issues that she's had for a lifetime. But I did find her external anal sphincter open and it was tight on the top half. The bottom, however, the bottom half was definitely being pulled posterior, and the intrarectal fascia was tender on her left-hand side. And so then I saw her two more times, but our time together really was spent more on exercise and how to activate her core and things like that. Um, and she's feeling she's getting stronger. Her tailbone was getting better, but still really sore. When I saw her after her fourth session, so this is the day that I just got done seeing her yesterday, she said her tailbone's much better, but it's not all the way there yet. She still has a problem from sit to stand. She has pain with that motion. And she's been doing bar classes and she feels like she's getting stronger, and she's not getting hurt. So that's the other thing. When she came in initially, she's like, I'm trying to get stronger, but every time I go to do something, I hurt myself. So I can't figure out how to get myself strong again. Um, when she has, then she was also describing her tailbone, and when she goes to contract her pelvic floor muscles, that's when in the first part of that contraction is when she finds and when she has pain in her tailbone with her pelvic floor muscles. And so what I found this time, and I realized that the last couple of sessions we hadn't done intravaginal work, and so I'm like, all right, we're going to make a point of that this time to work on that. And I still checked her pelvis, her bones, gave a little bit more work to the sacral flexion. And then what I found I was doing is actually distracting her tailbone a little bit. And that distracting it and offering compression to the ischial tuberosity um, to go medially. And as I did that, she's like, oh my God, that feels so good. And I believe what was happening was when I palpated her right coccygeus muscle and tendon, that sacrotuberous ligament was tender. And so I knew that there was this pull happening on the right. And so as I just traction the sacrum, the tailbone inferior, just offering a little bit of pressure there, I was pressing in on the ischial tuberosity, and that she was like, "Oh, it feels so good," and that helped that area to release. Um, when I went to do intravaginal work, um, her external anal sphincter had scar tissue at from like 9 o'clock to 7 o'clock. And it was almost like there was this divot or hole in that section of the EAS. I could feel everywhere around. And then it was just like the tone of that muscle just disappeared. And so I found that interesting that usually when I find tears or, grade 3, 4 tears, it's usually from 9 to 3 o'clock on the upper part of the circle of the sphincter muscle, but hers was actually on the lower right-hand side of her sphincter muscle. Um, and also found her internal sphincter as well was tight, and the intrarectal fascia was also very tight on that right-hand side as well. And what I felt with her is as I was working with the sphincter muscle and the tailbone, it was like there was just this tug of war going on between the two. And as I released the sphincter muscle and got rid of the scar tissue in that area, the tailbone kind of softened and relaxed back up so that there wasn't this weird tension. Seesaw is kind of the feeling I got of that muscle and bone connection there because of the anococcygeal raphe that connects the sphincter muscle to the tip of the tailbone. And if anybody is dealing with coccyx pain, you must check out that sphincter muscle and release the sphincter muscle. And because they are so intimately connected that I personally believe we're not going to get full resolution of the tailbone pain until we release the sphincter muscle. And after I got done doing the intravaginal work with her and releasing the sphincter muscle, releasing the tailbone, she was able to stand up and down without any pain. She was elated. So that was pretty cool. That was my first patient of the day. So the next client of the day was a gal who back in December had a C-section. When she came to see me, she was only 3 weeks post the C-section. The baby was born at 33 and a half weeks and was in the NICU after his birth. She had preeclampsia. She tried for induction, but didn't get very far before she had an emergency C-section with full anesthesia. And she was having a little bit of pain in her C-section scar. Um, when I evaluated her, this is again back in December, her nervous system, it was like it didn't know what the heck had just happened to her. Um, there was so much shock and trauma in her nervous system in her body, and it's like it couldn't relax back down. Um, so I worked on helping to down regulate the nervous system. The uterus didn't know what happened. We went to replay the birth in a better manner, and that helped a little bit. For the scar tissue, though, I just felt all this fear, and I realized that it really wasn't hers, that it was actually the doctors and the nurses that were treating her because they were afraid for her, what was going on. And so we released their fear from her C-section scar, and everything just kind of softened. It was pretty cool. And then afterwards, her body just felt way more relaxed. The scar tissue was way more pliable, but it still needed some more work and everything. So I taught her how to do that on herself. Then I saw her the next month. So I saw her probably 3 weeks after that appointment. No, 5 weeks later. She was physically doing much better. She feels like she has her own body back, but sex was still painful for her. She had insertional pain. And the scar tissue, what I found was her scar tissue was pulling down on the right. She had right round ligament pain. It was tight. She had better mobility of her scar, but was still, I did some work on that, but released the round ligament. And internally, her introitus was really tight. The bladder and cervix, I found more on the left-hand side, but she had good relaxation of their pelvic floor muscles. So after releasing all that scar tissue and helping those tissues, her introitus, definitely everything felt relaxed and felt much better. So we were working on core activation and getting her stronger there. She had more toned upper abdomen was kicking in more than the lower, so we were working on that. But she was very, very aware of her body, which was pretty cool. Then I didn't see her for another 3 months, and then I just saw her the other day. And she, when I asked her about intercourse, she's like, "Well, we found one position that works well, and we haven't really strayed from that." I'm like, "Okay." And so I asked her what side it was, and she said, in left side lying, she's able to have intercourse and it's no problem. Well, when I did the intravaginal work or assessment, I found that her left side of her introitus was really tight. Her cervix was pulled over to the left-hand side. And so there really wasn't much space on the left. And it made perfect sense to me why they found that more comfortable, because if she's on her left side, they're going to be aiming more on the right side, which had more space for her. So my goal in this session was to help create more even balance and get the cervix more midline and be able to move out of the way. When the cervix is pulled off to one side, if the penis hits that side and it can't move, it's going to be painful. My goal with all cervixes is to make it like a piñata in there. We got to release cardinal ligaments, uterosacral ligaments, and we've got to make sure that that cervix has free mobility. And it needs to be like a piñata moving around in a circle and be able to move up and down. So working with those uterosacral ligaments and releasing those intravaginally is super, super helpful when we have any pain with intercourse. So that was pretty cool. I told her her homework, which was to try intercourse in all positions, because I really feel like when I got done with this session, she had good mobility intravaginally and should be able to handle any position sexually. And I wanted her to go test that out and let me know. And she goes, "Oh, my husband's gonna love this homework." And I love that when we're like, yes, mobilization is the best way to keep the tissues moving, and intercourse is the best way to make that happen. The next client that I saw yesterday was someone that I've been seeing off and on for a long, long time. And this is something that's so interesting. She had a very serious bike accident um, uh, 4 or 5 years ago. Or no, probably even longer than that. I forget exactly when, but every year on the anniversary of that accident, her body starts hurting again. And the pattern of that injury just kind of rears its ugly head on her. And she thought she was going to get by this year, but no, her body started hurting. She had this one pain in the left groin area that we've worked a lot on over the years, and a lot of it's emotional. A lot of it was the trauma. She not only had that trauma with a bike accident, but she also had a traumatic way that she lost her dad very suddenly, and the way she was told and how it was handled just wasn't handled very well when she was a younger child. And so her body's just been processing a lot of that. And it comes out in pain in her tissues, and that's when she knows to come in and see me. And this time she was having a lot of left hip issues, low back stuff going on. And when I went to evaluate her, it was actually all the problems were on the right side of her body. And that's just a really good reminder for everybody to remember that the pain is not always where the problem is. I found her right ischium splayed. Her right PSAS just wasn't sitting the same way as the left side was. She also has a slight shorter leg than left leg was shorter than the other. And so there's this anterior rotation happening in her pelvis that she presented with. And I find a lot of times that when we've got these rotational patterns in the pelvis, that there's usually a uterine restriction going on with that. And so I did find, and I didn't take good notes with her because I didn't. And so I'm not remembering exactly everything that we did, but I did find a restriction in her uterus and internally with the cervix not wanting to move very well internally as well. And so, what I thought was very interesting that I wanted to share with you all is to understand this idea that when you've had big traumatic events in your life, that on the anniversary of that event, the body remembers and it can rear its ugly head again. So just keep that in mind if you are seeing someone and they're like, yeah, every year at this time I get this. They may need help with whatever that event was at that time. You could ask them, did something happen around this time of year for you in your past? And see what they have to say about that. Okay. But yeah, I was able to help this gal get things more balanced in her pelvis, and her body definitely felt better when she got up off the table, and she felt more balanced and even after the session. So my next client is a gal that this was my second session with her. She originally came in complaining of leakage. So not more urgency, not leakage with urgency, not stress incontinence. She has not had any kids, and she is wondering if she's in menopause. She thinks she might be. She was having constant spawning, so she got the Manera IUD placed. Um, and so she's had all these issues. And so I saw her one time, and then yesterday was when I saw her for the second time. And she was complaining. She's like, I just can't get my pelvic floor muscles to work very well. And she's still having leakage when she gets that urgency. She was said that with her first session, after her first session, that the leakage got better, but then it came back, and then it got to the same level. And so it got better, but then it got worse again. And to me, that was a sign that whatever I did last time wasn't the root cause, and there's something else that I need to do. So I worked on releasing the uterus from the bladder. Externally, it just felt like the uterus was kind of stuck and glued on the bladder. And so I did that work externally. And then internally, I definitely found her cervix posterior. And then it was really tight on the left near the bladder and the cervix. So I was working on releasing that. And after I did the work with the bladder and the cervix, her pelvic floor muscle was much better. She had greater activation and holding ability. Like before I did that work, she could just barely hold it. And then we were able to, with a good exhale, she was able to really hold it much, much longer. And then I had also talked to her about urge suppression activities, like if she gets the urge to go, if she raises up on her toes to activate the calf muscles that are innervated by the same nerves as the bladder, and how to try to stay calm, not get anxious as you walk to the bathroom, try to slow down, all those things that we know to help decrease the urge suppression. And what was so interesting with her is she gets off the table and she says, well, if I do those calf raises, will those still work even though I had surgery on this one Achilles? And her calf on her right side was definitely smaller than the other side. I go, wait a minute, what'd you have done on that calf? And she said that she tore the muscle off of her Achilles tendon. And so they went in and tried to, they did some sort of Achilles tendon repair or muscle repair in there years ago. And it just never really fully took. So she lost some of the muscle mass on that side. And I was like, wait a minute. My brain went ding. There is, with TENS, with NMES, we can do a stimulate of the tibial nerve, but we can stimulate that to help decrease this urgency in the bladder. And so that just like, wait a minute, let me see something. So I had her lay down again. And I just went and put my hand on her bladder, and I would just listened locally at the bladder, and my hand got drawn down on her right side. And when I inhibited her calf, the bladder released. And I'm like, I wonder if it's the scar tissue from the surgery that is pulling on the bladder. So I kept my hand on the bladder and I just started at her heel and worked on and felt the connection between my two hands. And as that released and the bladder let go, I would move my hand up a spot on her leg, feel the connection between my two hands, get that to release. And actually, the strongest pull was right where the gastrocs insert into the tibial plateau or to the upper part of in the knee joint itself. And as I was like, whoa, this is a really big connection between like the top at the insertion point of the gastroc and the bladder. Release that, and I continued to go up into the adductors, and I could feel the connection from the adductors all the way up into the bladder. And I just kept working in different sections until I was able to, once I worked my way all the way up, I then worked my way back down and tuned into bladder and had my hand on the adductors and go, okay, there's no connection there. Worked my way down, no connection there, and worked my way all the way back down to the Achilles insertion into the calcaneus. And there was no connection there anymore. And then I had her stand up and she was blown away. She said, whoa, that feels so light on that side. And my leg has never felt this free before. And my bladder even feels different. And she could really, really feel the disconnect that happened during that session. And all of that was, there is some knowledge in there, understanding that there was I think a CSM presentation that I listened to one year that was talking about stimulating somewhere on the calf area to affect bladder connection. And that's what spurred that thought of, wait a minute, I wonder if scar tissue could be impacting her bladder. Now, I haven't checked in with her to see if that was effective in monitoring or managing her urge. But the fact that she felt so different going down that leg makes me wonder if she's not going to have some major changes in there. So that was a really cool one. I'm hoping that did. The next client that I saw yesterday is a gal that I've seen. This was her fourth visit over 4 years, I guess. I first saw her in 2020 or in 21. She had a 2.5-year-old, and she had a very traumatic birth with that one. So we did a lot of work on that. She had scar tissue. And then I saw her a year later in 22 because she wanted to get pregnant. Um, and we were working on really birth or pregnancy prep with her. Saw her a month later again and was really working. She is so in tuned with her body, which is just amazing. Not many people are. And so it's really fun to work with someone when they really are attuned. And we worked more energetically and worked on the left side, right side, feminine, masculine energies and balancing that up and really preparing her womb space to receive a pregnancy and found out more of what she needed in her life to help cultivate some of the energy that was lacking in her. And by the end of the session, my note says that the pelvic space was even, bright, and ready for baby. So that was the prep work that we did. I saw her yesterday, and which is now a little less than 2 years later, and she has a 10-week-old baby that she just gave birth to and did a free birth at home with her husband. And the birth went great. However, she did say it felt like the birth was too fast for her body. She barely had to put, I think, maybe 2 pushes, and the baby came out. But she did feel like there was a lot more pressure posterior this time than she remembered in the first birth. And so she said she felt a lot of pressure on her rectum as that baby was coming through. So she was wondering, she had not been checked out by a midwife or a doctor or anything after the birth of this baby. So I felt really like, okay, I got to check things out for her because no other health professional has really looked at this space. She said she did tear, but she didn't have anything done with it. She literally laid low and was in bed for 2 weeks, which, I just find the more that moms can be horizontal for as long as possible after birth, the better their body does with healing. And she did pretty good. When I went to evaluate her, she had a tear, but it was up at like 10 o'clock in her labia. And it healed really beautifully. She had been doing some scar tissue massage. So she had taken Rachel Garcia's innate postpartum traditions course. So she felt very empowered and educated and really wanted to do things differently this time after this birth. And she did. So she's been laying low. She did a little bit of massage on that area and just really is very attuned to her body to know what her body wants and needs at any time. So she was concerned, though, with all that posterior rectal pressure during the birth, if she's having any prolapse of her bowel. What I found when I evaluated her structurally is that her left ischium was definitely splayed and her left rami bone was hard. When I asked her how she birthed, she actually was just in tall kneeling. So I was expecting maybe the left leg to be up and out more, but it wasn't. She was just in tall kneeling. But the baby definitely put more pressure on that left side as it came through. Oh, this was so interesting. When I first tuned into her uterus didn't feel happy. And I just had my hand underneath the sacrum and top hand on her uterus. And as I tuned into it, it was like, oh, that uterus doesn't feel settled. And as I tuned into it, I was like, oh, wait a minute, I'm going to go with the bones first. And so I chose to, do the correction to the bones and get that left ischium splay taken care of, try to help that to go medially, get the sacrum out of flexion and get that mobilized in midline. Her left rami bone was really hard. So I worked on releasing that and really got her bones in a much more stable, happy position. And then I went back and I tuned into uterus, and uterus was like, now, getting the bones back into its more, rested place, neutral place, let's call it that, really did help settle the uterus for her. And I was amazed at the difference in what I felt in her uterus after just working with the bones. So internally, um, I said there was that scar tissue at 10 o'clock, but it did have some hardness in that either the ischiocavernosus or the bulbocavernosus there was a hard spot right near the scar tissue. But again, I didn't feel like I wanted to work on it right then and there. I went ahead and did other things like the intravaginal protocol that I teach. I checked out her bladder. Her bladder was pretty good. There was a little bit of resistance to and when I say bladder, it's really the cervical fascia. Sorry, I just can't remember that name. But that anterior wall is the fascia there. And there was some resistance on that left side to bring it forward. So I released that and helped that to come back. And the cervix was posterior. So helped do a bilateral rebalancing of the uterosacral ligaments, which helped cause that cervix to come more into its more midline position. And she did have really minimal contraction of the pelvic floor muscles. There wasn't this great, nice, big strength, which she was only 10 weeks out. So she's newly postpartum. And after I did the intravaginal work, there was a little bit more tone to and more strength to the muscles. But let's see, we did have some tension on the left side of her pelvic bowl. And as I was trying to release those muscles, she was very aware of them releasing, but then tightening back up, releasing, then tightening back up. And so I just stopped and I was like, okay, so what's going on here? What do you notice? What's coming up for you? And she said she started talking about her husband and him adjusting to having two kiddos versus just one, and how he's kind of struggling. And as soon as she started talking about her husband, her pelvic floor muscles relaxed. So I knew she was on the right topic. And I just kind of let her talk and asked a few questions. And she realized that her husband, taking care of her husband and trying to make things better for him, is not her job. And she was really resisting the tension on her left side was bringing in his unease and discomfort with having two kiddos and not figuring out how to settle and be in balance with having two versus one. And she was resisting that. And so, helping herself to recognize that, like, I'm not here to take care of my husband. I don't need to make things better for him, that he needs to figure this out on her own, like help that left side to release. And she didn't have to take his stuff on. She didn't have to help him. She was okay. And there was much greater balance to this whole space. Then I really, in supine, I really did not get any sense that there was anything going on with her rectum. But I'm like, let's check you in standing. And boom, there it was. The rectum is at a stage 2, almost 3, actually, at the opening. But the interesting thing is she's having no clinical symptoms of it. Like, she's not having any difficulty passing stool or initiating a bowel, movement. So I just really talked to her about the importance of keeping her stools soft and avoiding constipation, and what to do if she does get constipated, and really talked to her about that. I also did emphasize the importance of staying off her sacrum and not pushing that sacrum anteriorly, and allowing that sacrum to be able to float more backwards versus being tucked under, because that is the only really support that that bowel has. Uh, we know that the pelvic floor muscle contraction doesn't really help support the rectocele or help it to change that much. So I just told her, I'm like, you're still in early recovery, your body's healing. We never know. Let's just take the pressure off of this. Let's avoid constipation, avoid pushing and straining while you're having a bowel movement. And I definitely want her to work on strengthening and getting that pelvic floor muscle stronger. And so I'm actually going to be seeing her again in a day or two, and we'll see where things are at with her. So, very, very interesting case with having a free birth. There was nobody at the birth, just her and her husband, and everything worked out great. And she really was knowledgeable about how to best support her recovery afterwards. And luckily, things went smoothly. So. And then my last patient of the day was a gal who I saw during her pregnancy. She was pregnant with twins, so I supported her through that time. Actually, I only saw her 3 times. So um, I saw her once during pregnancy, and then once after birth. And then I just got to see her yesterday, where her twins are 9 months old. And she says that she feels like she has to pee a little bit often, but not as bad as when she was pregnant. And she does have some sneeze pee, but not much. And she feels more like back to herself. And she did have a C-section to deliver her twins. She was also asking me about diastasis and assessing to see if she had diastasis, and she said that she was considering um, a tummy tuck. And she saw a surgeon when she was 5 months postpartum. So she was sharing that, and I go, well, okay, would you mind standing up, and can you just show me your belly in standing? I really like to look and assess any diastasis, any belly issues in standing, to see what happens to the abdominal wall in that gravity position. And so she stood up, and I mean, she kind of had a belly that most people would envy, especially 9 months postpartum. She did have a little bit of a bump, just a tiny little bump right above her umbilicus, and her C-section scar. She had no shelf, everybody. It was crazy. Like, her C-section scar was just as even and smooth as the rest of her belly. And so when I shared that with her, I was like, wow, you don't have a shelf like most people. And she's like, oh, I was wondering about that. What is that? And so I just shared with her, I said, look, you need to do what is best for you. Whether you are not okay with your belly, then you should go get surgery if that's what you choose to do. I'm just letting you know, I see the gamut here. And most people that I see would be envious of the belly that I am looking at right now. And so she's like, well, I don't really want to have surgery. And I go, well, good, because I don't think I would mess with what I'm seeing here. She had zero stretch marks for carrying twins. It was crazy. And her belly just looked amazing. But again, that's not my judgment to put on someone else. And it is completely up to them how they feel about their own belly and what they want to do. I just shared with her some of the clinical things that I know and helped her to understand a little bit more about what happens during a tummy tuck. And she was aware of the recovery process and not being able to work out for a couple of months. She goes, I don't want that to happen. And so I just kind of helped educate her a little bit more on that process. Now, I did note that there was just a little bit of a bump right above her umbilicus in standing. When I went to evaluate her in supine, she did have like a 2 finger separation. She said when she saw the plastic surgeon at 5 months that she had a 3 finger with diastasis. But I showed her how to do the oblique release because she is carrying 9-month twins that, her side to lateral trunk is going to get tight carrying those babes. So I wanted her to know how to release the oblique muscles, help bring the recti muscles back to the midline. And it was amazing how much it really went from 2 fingers down to 1 finger. And the depth was probably a couple of inches. It went down to an inch of length where the depth was deeper. And right where I could feel the bulge above her umbilicus really kind of tightened up. So I'm hopeful for her that with her continued strengthening and working out, and she did say she's like, well, yeah, I'm so glad I didn't do anything with the surgery because my belly has changed. And I said, I really don't recommend you doing anything until you're at least a year out from stopping breastfeeding. Was what I shared with her, and she's currently not breastfeeding her twin. She tried and it was just too much. So she's no longer breastfeeding, but I told her, I was like, I would still give yourself another year before you even try to make that decision because you're still going to be shifting and changing. So she was happy, happy, happy to hear that. I did work on her C-section scar. It was tighter on her left-hand side and release that. And then whenever I'm working with C-section scars, I want to work on it externally and internally as well, and just release that anterior wall and that cervix and make sure there's good mobility there between those two. And we did find tightness on her left side intravaginally as well. And I released that, and she had really good strength of her pelvic floor muscles and really good tie-in to her TA. She's doing some core workouts that I just kind of watched her do a couple of things, and she was doming. And I helped her to feel the hard doming. Like I was impressed with how well she was able to do one leg lifting up and then the other leg lifting up, and then she was able to extend both legs out and pull back and had really good, it felt like really good control. But then I did that on my foam pad. I'm like, let's get you down on the floor and let me see what's really going on. When she did the double leg extension out, she was hard doming in her linea alba. And so I helped her to feel that, and then had her just do one leg and then the other leg. And as she was feeling that, she could feel that she could do with soft doming, and helped her to appreciate the difference between the two, and explained why she wants to avoid that hard doming. And I just feel like if she can continue to avoid that hard doming, she, should really be okay. And she was super, super grateful for the information, the knowledge, and how to help support greater healing in her abdomen. And yeah, it was just such a cool day in the clinic. So that was all my clients. That's one day. That's all that I saw 6 people yesterday. And I just thought each one had a unique kind of something that I found that I wanted to share with you guys. So I thought I would give you a sneak peek into a day in the clinic with me. So I hope you found that helpful. Maybe learned a few points, or these are just highlights. I didn't go into massive detail, but just kind of sharing with you what I found, how I treated it, how I approach things, and just really looking at that body in a more holistic manner. I think really helps us in getting deeper results, getting more complete healing of our clients. So thank you for listening in. I hope that was helpful. And here is to smoother births and faster recoveries. Take care, everybody. See you on the next episode.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.